Welcome! I am so thrilled you're tuning in to this explainer today. We're going to be diving into something that is incredibly common, deeply frustrating, and honestly pretty misunderstood. We're talking about adhesive capsulitis, or as you probably know it, frozen shoulder. We're going to take a clear, really visual journey right through the whole life cycle of this condition. We'll look at exactly what goes wrong deep inside the joint, how to spot it, and, crucially, the evidence-based roadmap to getting your mobility back.
Okay, let's dive into this roadmap. First up, what exactly is frozen shoulder? Then we'll hit the 3 stages, followed by diagnosis and red flags. After that, we'll cover evidence-based treatments, and finally, the road to recovery.
So, part 1. What is frozen shoulder? The unseen threat.
To really grasp what's going on here, we've got to look at the main shoulder joint first, the glenohumeral joint. Normally, this joint is just an absolute marvel of mobility. It lets you reach, lift, rotate, the whole shebang. But when adhesive capsulitis sets in, that beautiful biomechanics just comes to a grinding halt. It's a painful, disabling condition where the joint capsule gets inflamed, thickened, and severely stiff. Think of the joint capsule like a flexible, perfectly sized balloon encasing your shoulder, keeping all that synovial fluid inside to lubricate everything. Well, with a frozen shoulder, that nice flexible balloon rapidly turns into a tight, inflexible leather brace. It shrinks, it hardens, and it literally locks the bones right in place.
And this brilliantly illustrates something absolutely crucial. While only about 2 to 5% of the general population will ever deal with a frozen shoulder, that risk absolutely skyrockets, up to 30% for folks with diabetes. To kind of put this into perspective, let's picture a 50-year-old woman managing diabetes. She fits the absolute highest risk demographic perfectly, because while this condition most frequently targets women between 40 and 65, especially those dealing with metabolic or thyroid issues.
So how exactly does that flexible balloon turn into a leather brace? It's genuinely wild how the body kind of traps itself here. Let's walk through the microscopic pathology step by step. First off, inflammation develops right inside the joint capsule. Then, reacting to that inflammation, the capsule thickens and fibrosis or scarring begins. Step 3, adhesions form. This is basically your body gluing tissues together that are supposed to glide smoothly over each other. Fourth, the capsule actually contracts and shrinks down. And finally, step 5, the physical volume inside the joint drops. The shoulder literally runs out of room to move, and bam, the joint locks up.
All right, move into section 2, the 3 stages, the timeline of freezing.
So zooming out from the microscope for a second, our 50-year-old patient is experiencing an agonizing disruption to her everyday life, and it unfolds over 3 incredibly long phases. First is the freezing phase, and this lasts anywhere from 2 to 9 months. It's marked by severe progressive pain as all that initial inflammation really sets in. Then, as the pain eventually starts to plateau, she enters the frozen phase. That's 4 to 12 months. During this time, the pain might actually ease up a bit, but the stiffness absolutely peaks. Finally, we reach the thawing phase, lasting a grueling 6 to 24 months, where that movement very gradually starts to return. The daily functional impact of these stages is just profound. Patients are dealing with severe pain that is notoriously worse at night. It completely wrecks their sleep quality. And simple acts of daily independence, they become monumental struggles. Reaching behind your back to hook a bra or thread a belt? Yeah, you might as well be trying to solve a Rubik's Cube behind your head. It's that hard. Because of the massive loss of both active and passive rotation, the shoulder is essentially paralyzed by this progressive stiffness.
Which brings us to section 3, diagnosis and red flags, investigating the joint.
Now, before a medical professional can confidently say, yes, this is frozen shoulder, they absolutely have to rule out some major emergency red flags. For instance, if there's a physical deformity after a recent trauma, well, that points to a fracture or a dislocation. A fever happening alongside a swollen, red shoulder, that suggests a dangerous joint infection. Things like rapidly progressive weakness, severe unexplained weight loss, or brand new neurological deficits, these are massive warning signs that demand urgent evaluation. Honestly, these are definitely not your standard frozen shoulder symptoms.
Okay, so once those emergencies are ruled out, we really need to bust a major misconception here. People often think it's a rotator cuff tear, but it rarely is. The real difference comes down to passive mobility. With a frozen shoulder, the arm is globally stiff. It physically cannot be moved by the patient or the doctor, especially when trying to rotate it outward. A rotator cuff tear, on the other hand, causes pain with very specific active movements, and you'll see noticeable weakness. But a doctor can usually still take the patient's arm and passively move it through its normal range of motion.
The real key to nailing this diagnosis lies in what we call the characteristic capsular pattern. During a physical exam, it's actually fascinating to see. External rotation, so turning the arm outward, is the absolute most severely restricted movement. That's followed by a moderate restriction in abduction, which is lifting the arm out to the side. Internal rotation, that's usually the least restricted of the three. It's important to remember that frozen shoulder is primarily a clinical diagnosis based right on these physical exam findings. Things like X-rays and MRIs, they're mostly just used to rule out other issues like arthritis or those rotator cuff tears we just talked about.
Let's move into Section 4, Evidence-Based Treatments, the treatment arsenal.
Now, what's really interesting about this slide is that the primary defense isn't some miraculous surgery. It's actually targeted, structured rehabilitation. The first line of treatment always starts with patient education and activity modification, basically learning how to avoid aggravating the joint. Then, we use NSAIDs for pain control, just so the patient can actually tolerate moving it. From there, structured physiotherapy takes the wheel. We're talking passive stretching, active assisted range of motion exercises, specific glenohumeral joint mobilizations to really stretch out that tight capsule, and strengthening those deep postural muscles.
But of course, not every patient responds perfectly to the basics, right? So let's break down the escalating medical options for folks who need a bit more help. First line is our physiotherapy and NSAIDs, tackling early pain and stiffness. If the pain is just incredibly severe and not responding at all to the basics, we step up to second-line options. This means corticosteroid injections right into the joint to aggressively knock down that inflammation. And finally, if there is persistent, severe stiffness that's still limiting daily function after months of conservative care, surgical interventions become totally valid options. Things like an arthroscopic capsular release can be used to literally go in and mechanically break up those stubborn adhesions.
All right, final stretch. Section 5, the road to recovery, reclaiming mobility.
We've made it through the darkest, stiffest parts of this condition together, so what does the actual timeline to get your life back look like?
Well, it's 1 to 3 years. I know, that's a long time. But that is the honest, medically accurate reality we have to prepare patients for. It takes immense patience. And, thinking back to our 50-year-old diabetic patient, we have to note that folks with diabetes often face a slower recovery and unfortunately have a higher risk of persistent residual stiffness compared to the general population.
Let's see how this builds into an actionable, daily strategy to speed things up. Getting into early physiotherapy dramatically improves function and quality of life. But listen, just going to the clinic isn't enough. A consistent home exercise program is absolutely vital to keep that capsule stretching every single day. For diabetic patients, maintaining really good blood glucose control is a non-negotiable part of healing. Overall, the strongest evidence out there tells us that combining hands-on manual therapy with active exercise is the absolute best way to accelerate that thawing phase.
I really want to leave you with this powerful, evidence-based message straight from the clinical literature. With early diagnosis, evidence-based physiotherapy, and consistent rehabilitation, most people regain shoulder movement and return to normal activities. Look, frozen shoulder is a grueling marathon, no doubt about it, but it is one that the vast majority of people do successfully finish.
Understanding the microscopic changes, respecting the long timeline, and fully committing to evidence-based rehabilitation, these are your keys to unlocking a frozen shoulder. The roadmap is clear, and the tools are definitely available. So the only question left to ask yourself is, are you ready to reclaim your mobility? Thanks so much for joining me on this explainer, and keep learning.